Hi everyone, thanks for listening to all my presentations. Today I'll be talking about liver abscess. Epidemiology. Liver abscess is the commonest type of visceral abscess. Pathogenic liver abscess is about 15% of all intra-abdominal organ abscesses. Liver abscess is more common in men, and about 3 cases will occur per 100,000 people. Taiwan has the largest record of liver abscess in the world. What are the possible risk factors? Diabetes mellitus, biliary disease, hepatic disease, pancreatic disease, liver transplantation. East Asia with Klebsiella pneumoniae is a strong factor in pyogenic liver abscess. Still on risk factors, chronic granulomatous disease, which means genetic recurrent infections, could be a culprit. Pyogenic liver disease due to Klebsiella pneumoniae has been linked to underlying colorectal carcinoma in Asia. Travel to endemic regions like Africa, India, Mexico, Central and South America could be another factor. Pathogenesis. Liver abscess will occur when a portal vein with pus from bowel leakage and also due to peritonitis. Direct spread from biliary infection like cholecystitis, cholangitis, or malignant obstruction could be responsible for liver abscess. Seldomly, abscesses can emanate from surgical or penetrating wounds. Systemic circulation spreading pathogen is not ruled out here, meaning the liver abscess we are dealing with today might be as a result of systemic pathogen that has been spread through the circulatory system to the liver. Culprits here could be polymicrobial organisms or polymicrobial agents. Enteric facultative means with anaerobes have been implicated as well. Examples of pathogens specifically are E. coli, Escherichia coli, Klebsiella pneumoniae, streptococcal species like Strep aeruginosus, Strep constellatus, Strep intermedius, and Strep pyogenes. Staphylococcus like Staph aureus, Candida co-infection and Bartonella fasciola, and of course Mycobacterium tuberculosis. What are the possible clinical features of liver abscess? There could be abdominal pain, mostly at the right lobe of the liver, fever, nausea, vomiting, anorexia, weight loss, malaise, hepatomegaly. Right upper chondral tenderness may or not be present, and of course jaundice. How do we make the diagnosis here? Thorough history of any infection, history of travel, and so on. Thorough physical examination. Then we embark on investigations, radiological investigations, as well as laboratory investigations. Now, radiological investigations. You can have ultrasound done to start with. If you are not convinced, have CT. If you are in a center that is, sophisticated, you can have MRI. That will become necessary if there is hyperbilirubinemia, transaminitis, right upper chondral pain, and can be done in the face of persistent and unexplained fever. Still on radiological investigation, we can have radiological guided abscess aspiration for diagnostic purpose. That would be very great. You can aspirate for microscopic culture and sensitivity, and that will be likely prevalent, right? Aspirate for anaerobic culture and gram staining. You can get the aspirate for fungi and mycobacteria. You can get the aspirate for polymerase chain reaction of antimobile histolytical. This is very, very necessary, very, very important because liver abscess could be missed or misdiagnosed or wrongly ruled out when it is actually present. But if you've done all this, you are not likely going to miss it at all. Now, still in the lab, the good guy or the good lady has come, the sample has been taken, and now we're expecting the result. What are we likely going to be getting when the result is back? Increased bilirubin, increased liver enzymes, increased ALP, increased white blood cell count. Because the liver is now under insult, decreased functioning, right? Low albumin, low hematocrit. And we can embark on blood culture. Stool antigen for antimobile histolytical. Remember, we can have serology for antimobile histolytical as well. Okay, blood, urea, nitrogen, and creatinine. What are the possible differential diagnoses? The other time I said, if we don't carry out appropriate investigations, thorough history, and thorough physical examination, it's very likely to miss the diagnosis of liver abscess or misdiagnose liver abscess. Rule it out when it is actually in. And we might think we are dealing with hepatitis, metastasis to the liver. We might even think it is hepatocellular carcinoma or pneumonia of the right lobe, cholangitis, or cholecystitis. Okay, now to make definitive diagnosis of amoebic liver abscess as part of possible differential diagnosis, we can have thorough history of travel to endemic zone in the last 12 months without running down or insulting any part of the world. History of travel to Africa, Asia, Mexico, Central and South America have been listed. Okay. Now, it is possible if you are in certain parts of the world not to identify amoebic liver abscess via the history of endemic zone traveling. So we can now identify without the history of travel in Australia, US, and Europe in some patients. Then ask me, how would they do that? All those gammas of investigations will be done once they are suspecting it. So they don't want to insult anybody. They don't want you to feel that, oh, you think my country of origin is this and that. No. They will just carry out all those investigations and conclude. As a simple cyst, necrotic tumor, or biloma, that is collection of bar, could all be differential diagnosis. Treatment. I remember in those days when we were in medical school and surgery department, our prof would say, particularly in general surgery, that all abscesses, first thing first, I&D, meaning incision and drainage. All abscesses must be drained by incision and drainage. Then we have to cover with a broad spectrum antibiotics. And why that? Remember, we've said the culprits could be polymicrobial. Both anaerobic and facultative bacteria could all be found, including fungi. Still on treatment, the drainage could be percutaneous with CT guided or ultrasound guided. Then needle aspiration, catheter placement, open surgical drainage, or laparoscopy. And it could be by endoscopy, retrograde cholangiopancreatography. You're familiar with that, right? Then we'll cover with antibiotics. I'll dwell more on this because it's very important. We have to cover all possible microbes, particularly if we are not yet having the lab results of the gram staining, microscopy, culture and sensitivity, and then staining for fungi and so on. So we have to cover fungi, gram positive, gram negative, anaerobes, and mycobacterium tuberculosis. In that case, we can go home to sleep with the hope that the patient will be fine. Okay, so empirically, we can choose tazocine, that is the combination of piperacillin and tazobactam. Metronidazole for anaerobes and entamoeba histolytic. Rifampin to cover for mycobacterium tuberculosis. And of course, fluconazole or voriconazole if we are suspecting fungal infection. Even if that is not the case, just empirically so that you can have a good sleep with the peace of mind that you are helping the patient appropriately. Just cover for the fungal agent as well. Others could be fluoroquinolone or vancomycin and cephalosporins. You start with empirical therapy, then you change to specific medications when you have your lab results. Suggestions for empirical antibiotics could be, if you are in a poor region, sorry to say, if you are in an environment where the patient might not be able to pay for it and then the government is not covering it, then you can go for ampicillin with gentamicin and metronidazole. Why that? Ampicillin will handle the gram-positive agent. Gentamicin will handle the gram-negative agents. Metronidazole will handle the anaerobes and entamoeba histolytic. But if you are lucky to be in rich zones or rich country, you can go for tazocine. Remember, that is a combination of piperacillin and tazobactam, and metronidazole or ceftriaxone and metronidazole. Follow up. What are we expected to do? If symptoms persist, we have to repeat ultrasound, CT, or MRI. Like I said, it is very easy to misdiagnose liver abscess, to rule it out when it is actually in. But radiological features can persist for a long time, like up to half a year. You can then start surgery. Prognosis. Prognosis will depend on the need for open surgical drainage, cancer presence, or the presence of anaerobes. Mortality rate is about 10%. Complications. Abscess could rupture. And you know what that means. It could be sepsis, it could be septic shock, and it could be death. With that, I've come to the end of this presentation. Remember to leave your own comment. Remember to give thumbs up. Remember to share. And remember to subscribe to my channel. I appreciate it. Thank you.